Heidi ho, everyone. Thank you so much for joining us for Knowledge or Nonsense tonight. Tonight, we're going to be talking about HLD, scopes, a little bit about probes, and if there's anything dealing with COVID that we need to be aware of. If you have any questions, please send your questions in. My name is Sharon Combs with UCDI Leadership. And without further ado, I like to just jump in, and right after the first commercial quote break, I'll let you know a little bit more about our guest today. And so, hey, we're still in it. We're still in COVID. As a matter of fact, we're probably going to be in COVID for another 12 to 18 months at least. And so, with the scopes, have you all noticed anything as it relates to scopes and COVID? Have there been any adjustments that you've noticed some facilities are doing, or any questions that people are asking you about scopes and COVID that you feel like SPD Nation should be aware of, that the SPD and OR should be aware of?
Well, I can tell you about a very, very interesting joint article that I read. And in SPD, some of the familiar scope best practice groups that come to mind. One will be SGNA, that stands for the Society of Gastroenterology Nurses and Association. Another one will be AHGE, American Society for Gastro Endoscopy, and of course, AMI. They put out a joint article which was pretty detailed. I went step by step with some pretty amazing questions on how to handle scopes, do standard manual cleaning, followed by high level disinfection, eradicate SARS or COVID-19. And what was amazing about this article is that it's rare that you see a joint statement from all of these agencies that are all saying the same language. But without going into too much details, because I want folks to read it for themselves, is that there wasn't too much of a strong pivot from current standard best practice measures. And that was encouraging, right? It was still universal precaution, manufacturer's recommendations. The strongest pivot that I read was about environmental care and control, how housekeeping, if you will, or those team members are turning over the rooms, and how are they doing their due diligence with high level disinfection, EPA approved products, CDA regulated products to kill the virus that may linger on the surface. So that was the strongest pivot I saw. A greater definition on how to use these high level surface disinfectants.
Right. And something I've seen a lot on the field is, you have your a lot of staff members that feel like they're concerned about the situation, and rightfully so. It's pretty scary what's going on. But what we said many times in the show: stick to the drills. These standards and these procedures that we put in place are there for a reason. For the virus is just as scary, if not more scary than COVID-19. We have to make sure we follow the guidelines and the procedures. Since there's been a lot of elective surgeries that have been canceled out, and probably it's going to continue doing so now that a second wave is hitting. But time and time again I say we should always stick to the drills that we learn. Follow all the steps and procedures. No shortcuts. Shortcuts just puts not only you at risk, but also the patients that your facility is caring for. And another thing is, during this time, it feels a little weird almost using high level disinfectant. You want to go maximize and sterilize, and but remember these specific chemicals and cleaning agents and disinfectant agents are there for these viruses out there that make people very sick. So as long as we just stick to the plan and make sure we're constantly educating ourselves on what's up there and staying up to date with the literature, we'll stay ahead of this.
Yeah, I would agree with both of you. I will add, Dwayne, that the AORN guideline on processing flexible endoscopes is an outstanding document. It's probably the most evidence-based document around there. We looked at more than 1,300 studies when we developed that guideline. And we also have a guideline on high-level disinfection that is also very evidence-based. And I would remind folks that the COVID virus is an enveloped virus. It's much the same as the HIV virus. So it's really at the bottom of the chain insofar as infectivity and severity of being able to withstand those disinfection process. It should be eliminated with only low-level disinfection. It's all that's really required to eliminate that virus.
Yeah.
Wow.
What I've seen also, team, and what I know from being in the field is this, especially in SPD, we tend to defer and put our confidence on what I'm going to use the term AI, artificial intelligence, and I'll tell you what I'm pivoting to. We'll take the automatic reprocessors and put all of our confidence that that machine or that unit is an answer in itself, where every regulatory agency, especially SGNA, and the ones I mentioned earlier, all say the same thing. Manual cleaning is necessary before automation. Manual cleaning is necessary before automation. And if we were to reverse engineer it all the way back to the patient treatment site, bedside cleaning and scope reprocessing is also necessary before transmitting or transmission of that device down to the cleaners or the technicians. So we can't solely rely on automation. We need to train staff before we put our faith and trust in all of these new technologies. Some are old technologies, wonderfully designed machines. So manual cleaning, having those quality checkpoints, one major one, using, making sure if you can see it, if you can't see it, doesn't mean it doesn't exist, right? You have to do your due diligence and look inside those channels. So manual cleaning before automation.
And see, that's something what I've appreciated. So, I guess the silver lining about COVID-19 is from a lot of the facilities I visited, specifically the ones in Boston and New York, I've seen that, the different departments coming together. You see the surgical techs, you see SPD, you see nursing, you see the doctors all trying to come together and tackle this issue together, and then we expressed the importance of pre-cleaning. You don't want anything to dry up. You don't want anything to make the process harder than it already is. So, creating these committees where we're constantly conversing and, sharing information of what's out there, I think it's been a great situation that's come from this all. And I think we should continue doing that.
And you had mentioned, Luane, the training, and that is just so important. But I would add to that, we tend to use the word training kind of as a big, broad term to encompass everything. I think it's really important that our training includes not only those hands-on skills and the demonstration that the person has of the ability to clean the scope correctly, but that we also provide education, because I think that sometimes that just makes such an impression when we can share the results of these studies, and then people have a better understanding of why it's so important to adhere to those manufacturer instructions, why that pre-cleaning is so important. Sometimes, the results of a study can just make a really huge impression on a person.
No, that is a great point. The why is always important, and I share that time and time again. It's not important knowing what someone else is doing or what your colleague is doing. It's important knowing why they're doing it, because then it puts you in a very empathetic state, so you understand exactly what they're doing and the purpose behind it. So that why is.
We use the term TP, connecting the theory to practicality, or pulling that theory or that science and putting it in the hands of the technicians who can understand and articulate the why, the how, and the source. So, Sharon, very, very valid point. Thanks for sharing that.
Yeah, I was going to ask you about the training because it can be very broad. You know, training is something. It's the buzzwords. It's something that we use. But what are practical trainings like? Is it the educator working on site, like right there next to you? But let me go back to this with the why. I really feel like when the why comes in, it empowers those that are working in healthcare.
Mm-hmm.
Because when COVID hit, like if you just only know the practice, but you don't know the why, the moment something gets shaky, then you're almost like your hands are tied. You don't know what to do because you didn't know the why. You just kind of just wrote, just like a assembly line wrote type of, you just, that's all I wrote, or ROTE, just, just do. And when it's moved, it's almost like it doesn't compute for you because you don't understand the why. But if you have an idea of the why, if you get an understanding of the why, even when things shift, you still understand why you're doing what you're doing. So you're not just going to pull, you're more empowered in being able to work with the tools that you have. Kind of like learning medical terminology. Somebody may call it a different name, but when you begin to understand it, you can say, no, okay, we don't have any of that instrument. Here's something that can work in its place. It empowers you to be able to move more and do more. So what are some ways that some practical ways that people really can train people? Instead of just saying training or sign off on a competency, because you can get signed off on something and you still don't know what you're doing. I'll say it, you guys don't have to. You can get signed off on something, and if you don't do it or it's not something that you practice all the time, especially if you're working at a different workstation, all of a sudden they need you to go back in there. Well, I haven't been in there in 6 or 8 months. You may not have it. So what are some practical ways what are some methodologies? What are some approaches that we take to training so people understand what's going on? And I'm trying to make this as plain as I can.
Right. Well, it depends on what aspect you're asking. Are you asking more as the teacher themselves or the listener? And I think it's important. Both aspects are important. As a teacher, you should always make sure that the audience is being receptive. That you're explaining it in a manner that they understand. You're not going to explain to someone that's new to the process the same way that you're going to explain to one of your colleagues that's very educated and well versed in it. As a listener, I feel body language is always very important. If you're slouching, if your hands crossed, the study that Amy Cuddy in her TED talk that she did about fake it till you make it, the power of body language, goes to show, explains how depending on your body language, it makes you receptive on the information that you're hearing. So if you're all closed up and you're not even there, you're not even mentally present, you're not going to be able to absorb and necessarily be able to utilize that information that's being given to you. So, and in both aspects, as the professor or the teacher or the educator, and as well as the person assisting, I think you should always be present, with really ready to apply that knowledge that you're gaining.
Okay, so go ahead, Sharon.
No.
More of nowadays for those multidisciplinary teams. And I think that is so important because especially folks in sterile processing, I think, tend to think that they can't teach anybody anything, and that is so wrong, because even some of those physicians and surgeons who are using those scopes, they know how to use them as diagnostic tools and how to get the best picture and that kind of thing. But most of them have never cleaned a scope. We used to have a surgeon who would, he was a urologist, and he would forever close the lid on the ureter scope, and then it would come back and it had a dent in it, and it's like someone from sterile processing was able to show him that he was ruining the scope. So I think it's really important to have those surgeons and nurses and sterile processing team members, everybody working together, and infection prevention, so we can learn from each other.
Yeah,
totally agree. And it's so critical to monitor the language you use, right? Because we can be using industry-specific language or department-specific language that only SPD can adapt to or will clearly understand, versus something coming from infection prevention. An example, we were always told to fully dry the endoscopes to prevent outbreaks. Well, Someone from infection control is going to elaborate outbreaks of what? Waterborne organisms, right? And SPD, although we understand what a waterborne organism is, we possibly can't elaborate on the genome sequence or what that means, but we know, according to the manufacturer's recommendations, these scopes should be fully dried during this storage process.
Okay, so I just want to interject right here, because this is what I love to do as far as being able to host, because definitely there are people, the interdisciplinary team, the interdepartment, I love that, because we do have our own jargons. Even though we all work within the same scope, each person has its own jargon. So I like to make things very plain. And for the educators that are out there, even with scopes, like we're talking about scopes, you still want to know your audience, because when you are speaking, like she said that about the physician, that's like a costly, that's a costly mistake when you're running. Scopes are not the most inexpensive items. So, that can be costly, and they can have an effect on the budget and everything. So whoever your audience is, you do want to tailor your language so that it's receptive. The physician may never, he's probably not going to do a leak test. There's some things that are not going to happen there. So you want to be able to use language so that even if you're doing a training there, you still have to use the language for your audience. And so I wanted to ask, I'll wait on that. Yeah, so you do want to know, who your audience is.
I'll give you an example that
go ahead.
Concerning the language. I remember at one of the sites I was at, the doctor was upset because he needed a specific instrument, and he didn't know what the name was. So he said, "Oh, that bendy metal tool." So the surgical tech said, "Oh, the crumb scraper." And it's funny, I was just talking to one of the nursing directors about this, and they said, "SPD, we need this crumb scraper," and we're just a crumb scraper. We're there Googling what's a crumb scraper, and lo and behold, it's a malleable retractor. So then we all had a learning moment. Like, look, we're talking about one specific thing, but we all had a different jargon, a different name for it. But it all put us on the same page. All right. And from that point on, we're like, going forward, this is going to be called a malleable retractor. So we all know exactly what we're talking about. But that's how things get lost in translation and in the communication. Sometimes there isn't that communication, like, hey, we need X, Y, Z. Hey, this is what it's used for, and it breaks down that problem solving situation. So everyone's just like hands off about it. I don't know the why. I'm just concerned about the what, and the what means I have no idea what we're talking about, so I'm just going to leave it alone. So making sure we're all on the same page is always great.
Yeah, that's a great.
Hey, we're going to take a quick break. Sharon, you had mentioned something earlier saying that sometimes sterile processors, sometimes people who work in sterile processing, they don't bring the education, or they just they don't share what they could share. And it could just be because, sometimes there's a chasm between the OR and the SPD, but a lot more, we're seeing less and less of that. I am seeing, and of course you guys been in the field so much longer than I have, but I'm really seeing where people are like, listen, we're a team. We're a team. It used to be you say, there's no I in team, and you may use it because it sounds good, but I'm actually seeing where people are like, what is this? We're a team. How do we help? And so I just wanted to say, what are some ways, this isn't on the question list, but what are some ways that SPD can share information? And so Sharon, I'm going to ask you that, because, what are some ways, and you have a few moments to think about it. We're going to take a commercial. What are some ways or some opportunities, like opportune moments for SPD to share that information with audiences that may not be within the sterile processing department, like the OR materials, like some things, some information that they have? What are some ways or opportune moments for them to share that before there's a Midas report, before there's something drastic or a sentinel event? What are some opportune moments or some ways that we can introduce that interdepartment type of education and sharing of information? And I'm going to ask you that as soon as we come back. When we come back, I'm going to be like, go, Sharon. Okay. All right. Give us about 30 to 45 seconds. Please feel free to share this video. If you have questions, Ask us the questions. If there are some things you've noticed in your department that you want us to address, please put it in the chat box and we will be glad to just share what we can with you. All right, thanks so much, guys. We're back. Sharon, I'd ask you some ways or some opportune moments for people. She's just nodding like, okay, all right, let's do it. Yes, yes.
Yeah, you've kind of touched on an area that's really near and dear to my heart. And I'll tell you, when I was an educator, when I started in the operating room, those many years ago when dinosaurs roamed, I was very fortunate because the supervisor of the OR wanted me to spend time in sterile processing, which is unusual at that time, and it's unusual now still. So I spent like 6 months working in sterile processing as a new graduate nurse, and what that did for me was it bonded me with that sterile processing team, because here was new on the job. They were the experienced ones. They became the people that I turned to when I had questions and different things. And so when I became an educator, I did the very same thing. Now, we couldn't send all of our folks through sterile processing for 6 months, but we did put them there for 3 to 6 weeks during their initial training. And that had the same effect. You know, the first people that you come on a new job with, those are the folks you tend to bond with. You tend to develop those special relationships. And it kind of really helped them respect the work that the sterile processing team does. Further, they learned where everything was. They learned how everything should be cleaned. So it was the perfect place to start. And in that situation, the sterile processing person was the expert. The new employee was the learner. So it gave them, I think, the ability to realize I can teach people things, and I can speak up and say how things should be done correctly in that. And so I just highly, highly recommend that. Even if you can't do it for 3 to 6 weeks, if you can just do it for a week or, a few days, the old saying about walking a mile in each other's moccasins, it's just such a good learning experience.
Yeah, I was actually at a facility where you would come down and spend some time in SPD, whether it was a couple of days or the week. And SPD is a lot of time is forgotten. People just think, they're just opening a tray, closing it, and throwing it in the oven. That's it. A lot of people don't realize how meticulous technicians are going through those instruments, making sure they're at the top quality. And, I feel that us as leaders in healthcare field, we should be creating opportunities where typically the voice that's usually not heard or that does it is intimidated almost, I want to say, of not speaking up. We create opportunities for them to speak up, create environments of safe zones where, every member is equal. We're all sitting at the table. And actually, I always refer back to this TED Talk that Sheryl Sandberg had, and she's one of the top executives at Facebook. And her TED Talk is why is there so few women leaders? and she said that a lot of the times when there's these big meetings, it's always the men sitting at the table and the women standing on the edge of the room. And her message was always sit at the table. Make sure you sit at the table. Make sure you're present again at in the situation and speak up. So I always push that for when I'm speaking toward anyone in SPD. Not because of COVID-19, a lot of people were turning to SPD, how to process these masks. How can we go about disinfecting them properly? Because now they're seeing that we are the experts at this. So, always speak up, always sit at the table, and don't be afraid to share your knowledge. And yeah.
Yeah, another great, very valid points, team. Another, I think, amazing opportunity that we miss is one provided by OSHA, actually. So OSHA is bloodborne. We all know that OSHA is bloodborne pathogen standard 29 CFR 1910 requires that all employees offer that OSHA bloodborne pathogen training upon hire or at least annually, right? So it would be a great time as a segment to that training to have the OR come downstairs to sterile processing, decontamination, to truly see how that chain of infection is broken. And not only is it required by OSHA, but in during the training process, you get to see the entire process up until patient's bedside. In many hospitals, this training is now done in an auditorium, on a webinar. What greater way to have this training done as a part of your annual competency than to include SPD as a matrix that gets signed off. So there's lots of opportunities, team, to bridge the gap, to walk in each other's shoes, and to have a permanent seat at the table.
Yeah.
Okay. And I do know that there are some, like within the SPD field, like some of the educators and some supervisors, and because a lot of, I'm really proud of us, just period, because a lot of the gaps and that gap that we bridge, I've seen where a lot of people within SPD, they do go and they do look at a procedure, they go and see what's going on. So again, the why that we talked about earlier, if you get a little more understanding and not just get so focused on what you're doing, recognizing, but when you speak of this often, how every part is like, it's part of the whole, like it does have an effect. And so Sharon says, if the team gets together as a perioperative group, you can introduce information on an ongoing basis. And listen, I don't know, you may be a tech out there listening, you may be a OR manager, you may be a charge nurse. I don't know who you are who are listening, but definitely please get on board with the teamwork concept. I'll just leave that there. Please get on board with the teamwork concept. If you're spending time trying to assert how much you're doing versus how much some other department isn't doing, then that's probably energy that could be better used with the teamwork concept. It's a whole. It is a whole. And so let's use this time. This COVID has been great for us to work together. COVID has really made individuals have conversations, even in places where there was a gap, where they weren't trying to work really good together. But you know what? There's a silver lining in every cloud, I believe anyway. And COVID has forced conversations.
Yes, yes. And I was going to tell you, it starts at a simple word, hello, right? It starts at hello. You hear those best relationship stories, and they would say, "Oh, she had me when she said hello," or he said hello. Go up to a teammate that you don't know and introduce yourself. Find out what they do, what they contribute to the team, to their part of the flower, to their part of the vine, and exchange some notes. You'll be surprised how much can be accomplished by simply saying hello.
Find out their story. And that's why I always like championing creating committees and making sure that leaders stay out of those committees, because us leaders sometimes have great ideas that really that look great on paper, but executing them, they're just isolates you from the people on the front lines. But creating these committees, these interdepartment committees like SPD, surgical technicians, nursing, they're able to brainstorm together. A surgical tech says this instrument's always missing. The SPD person is like, we always put that it's missing, but you guys never read the missing report. So now we're creating that conversation among them. All right, now that we figured out, we found a common problem, let's find a way to best execute a solution for it. So that's why I always champion creating committees amongst the staff members, the frontline workers, because they're the best problem solvers. They know they could trace back the root of the problem and figure out what best steps to take to fix it.
Yes.
Another thing too that I wanted to mention is, and I think is very important, is that we have to remember that every person is an individual. And so if we're putting out our education and our training sessions kind of like in a machine-like kind of manner, we're going to miss those people who aren't catching it up along the way. And there are people who are shining stars who just get it the first time you show them. And there are people who take a little more time and effort to learn the process. And so we have to, I think, adjust our programs to accommodate all those people and not forget the ones that maybe just barely made it by that time. We need to go back and double check with that person and make sure that they have learned the process and they are able to perform the task correctly.
Absolutely.
And Danny, to your point about, I'm also a fan of committees. In some cases, I think leaders need to step out the way, help organize, but then step out the way. But the organizational ability is the personality types, right? You got to mix it up. You got to have the D's, the dominant personalities, with some of the steadiness, the S's, and some of the C's with the I's. You got to mix it up. That way, you don't get a whole table full of this dominant personality, and everyone has something to say, but no one wants to say anything, right? So that structure, plan it out, with intention.
Yeah, absolutely.
Yes, I do want to share. Let me just weigh in on that. As someone, I'm a human behavior consultant for many of you out there who don't know, and I have the honor of being able to work within the SPD and learn different things there. But leadership, John Maxwell, human behavior, personality insight. So when he's saying that about the D's, like, everyone knows that there are people who can speak first and speak louder, and maybe even speak fluently. Like, you may like the way they put their words together. But within any structure, you have those individuals, like what Sharon was saying, like, don't be so fast to move because they spoke and you assume that everyone else has this. You have to take the time, even going back to the training. And that's why I was like, what are some practical ways, or what are some approaches? Because you may think that everybody has it because they didn't say that they didn't have it. And because someone else is like, yeah, we have it, and they sign off. But that person really, they don't have it, and for someone who has a dominant personality, a response may be, well, they should have said they didn't have it. Well, in a perfect world, maybe they should have, but we live in a world full of many people, and they could have been over there still trying to get it and not even aware that you guys have moved on down the road. So you do want to have a mixture in the conversation. You want to have people who speak real fast, and you want to have people who take a little moment and consider the approach. How will this affect the team? Well, how will this affect the cases that we normally have? We typically have a lot of this specialty here. You want to be able to hear all of that. And for those of us who have dominant personalities, or we speak first or whatever, it would do us well. I like to use inclusive language. It does us well to learn how to stop and allow everybody opportunity, because these individuals work here day in and day out. So there's some things that they've seen, that they know, as Danny was saying, there's some approaches, there's some stuff that they know, and we don't want to bypass that. I just wanted to throw that in because Luane used the word D, and some of you may not know what D is, but it's a dominant personality. And then you have personalities who are just a little conflict avoidant, and they don't want to argue with you. They may have the right answer, but they don't want to argue with you to try to give you the help that you're asking for. Just calm down and listen to them. Okay, I'm through. I hope everybody got that. I know it was little layman's terms there, but what he's saying is be sure that you have a mix of individuals so that you can get a well-rounded approach and you can make a more informed decision. You know?
Indeed.
Yeah.
Communication and collaboration. That's the name of the game.
Somebody put, don't leave the single lamb behind.
Absolutely.
Yes. I love human behavior because the D would be like, come on, lamb. But there's going to be someone who's going to be like, hey.
Oh, I'm straggling. I'm straggling behind.
Yeah, get them.
Taking in the scenery.
So, hey, let me ask this question. So I want to go back a couple of weeks back. There was the article that talked about the scopes, and they were asking things about cross-contamination. And I know we hit it a little earlier, but this streams live on YouTube and on social media outlets. And typically within that, you have people who come and join. So I just want us to hit that one more time. With COVID, is there an increase in the likelihood of cross-contamination with things such as, like, I think it was the bronchoscopes? Is there an increase, or is it like, hold your form, remember the drill? Like, do people need to be heightened because of COVID?
I'm going to quote Miss Lila Price, stick to the drills and you'll be fine. Stick to the drills. Stick to what you've been training pretty much
the university
400 hours. And,
yes.
You'll come up ahead. No shortcuts.
All right.
Yeah. Well, I'm gonna just share what we stated earlier. There has been some studies to suggest that the room cleaning process, should be performed meticulous cleaning after each procedure. Of course, including all high touch areas and horizontal surfaces, using the proper disinfectant. We can't cut corners, right? We can't be timing our folks for room turnover and putting so much pressure for the next case that they miss a spot. This is not the circumstance that we can afford to miss a spot.
Right.
Yeah, I think that's one thing we can be thankful for, is that this pandemic has reminded us of the importance of cleaning those environmental surfaces. I mean, how many times have you gotten on a plane and just kind of went, you don't want to touch anything, you don't want to lean back on the seat, now those planes are being cleaned. So a lot of things I think that should have been going on, but were not, now are. So I think that's a kind of a blessing in disguise, if you will.
Yeah. The mind shift changed, because before COVID, we wanted those OR rooms turned over, new record, 7 minutes. Now, take your time, 15 minutes, okay, just as long as you made sure you did it right. You don't want to put your colleagues or the patients or anyone at risk. So no cutting corners.
Yeah. And we know, pre-cleaning, should absolutely commence in the procedure room per protocol. And typically should be done by the staff already in the room. Mm-hmm. It used to be mind-boggling when it's time to turn over a scope and you see someone brand new walking back from lunch from a different shift who wasn't there to see the entire dynamic of what's going on. So you're going to turn that room over and that scope pre-cleaning. Highly recommend it's done by the team already in the room.
Correct.
Already involved in the case, already understand the dynamics of what's going on. Rather than someone just tagging in on relief. And I know there's going to be some circumstances to that rule, but it is highly recommended that it's done by the team already there.
All right. Sharon is mentioning something that Corey Hofstad stated. The risk is no higher than it has always been with other serious pathogens, and everyone will be safe if they follow the practices. And I know we had touched on that before, but we're about 30 or 40 minutes in. It flies by. We're about 30 to 40 minutes in, and because people jump in at different times, I definitely wanted to hit that again. So, yeah, she was saying just follow the practices. Remember the drill. The same practices needed to prevent exposure to hepatitis, bacteria, just other things that we typically, those pathogens you're already battling. Look at me battling. You're already battling within SPD. Okay, so Amy says, This has also greatly changed the pace in certain retail environments. It's a different kind of running. Yes, how they're handling business. We were talking a few days ago, even though some people have been furloughed, but now all these businesses, they need people with this specialty to come in and tell them things about contact hours. And, you know, like, I won't get started on the pivot, but there are opportunities even in the midst of this pandemic.
Right. And we said,
Sharon, this pandemic has made those non-frontline folks superstars, right? I remember you tell folks, what do you do for a living? SVD. What is that? That's so boring. It's not as boring as you think, right? So now you understand. It's now common knowledge. A year or two ago, the public would have no idea what PPE stood for. Right there. Now PPE is a household term. You know, I would be surprised that when schools reopen back up, whether virtually or in person, the letter P is going to stand for protective, right? That's right. There's going to be special emphasis on terminology and nomenclature we use every day.
Absolutely, yeah.
All right, so hey, let's talk about some practical tools for the people, things that we want to make sure we don't forget. Because CMS and Joint Commission, they're visiting facilities. They're gonna start visiting facilities again because everything cannot stay on pause indefinitely. And so with the high level disinfecting, with the scopes, what are some things, if we could say something to the hospital executives, or well, let's start with some of the executives, like some directors of surgical services. If there were some things we could say to them to help them prepare, and like checklist items that we would want to share with them. What are some things we can share with them? Because they have a lot going on right now. I mean, everybody's dealing with COVID and less people. We're all navigating this. What are some tips or some areas we could kind of help them to look in so that they can be adequately prepared?
I always say
post-COVID
documentation straight. You want to make sure you have your data sheets ready, your when your expiration date on your bottle, even if it's not required in your facility. It's just so easy to know when exactly you opened it, when it expires. So when you're just passing by and you just happen to look, you know exactly when it's time to change it. When people make their rounds, these organizations, they catch you with the littlest things, and it's stuff that you thought was there. Oh, it's right here. Let me just check. And then when you check, it's not there. Meanwhile, you were stressing about making sure there was no tape on those or something like that. But make sure just your documentation is all in place. Your checklists are all checked out. You're doing those daily visual inspections of everything that you need to concerning the scopes and your machines. Any meters are being read properly and documented. Documentation is always key. Create that paper trail. So you could demonstrate that you've been following the policies and procedures this whole time. So,
what about you, Sharon? Go ahead.
I agree with the gentleman. I think that getting your documentation in place, and I really think having your policies and procedures in place is really important. And those are some of those tedious jobs, going through them, and you've read them so many times and making minor tweaks here and there, but they really can be your salvation sometimes in the case of if you have any litigation, or if you have CMS coming through and questioning something, and you can pull out your policy and say, here's our policy, here's how we do it, and show that your folks have been, their competency has been verified in that particular policy. I think it can be a real lifesaver. It shows that the facility cares, that you care enough to follow and strive for high quality care.
Absolutely.
And honestly, the devil's in the details. A lot of times we focus on the big things, but because we did not deal with the details, the big endeavors are crippled, or they don't go through as smoothly as they would go through, because those details are what holds it together.
That's right. Yeah. And I would share a tip is to create redundancy, right? I'm going to share something you can post. Creating redundancy is the duplication of critical processes or systems. You can't leave it to that one brilliant person, on a team, or the one nurse or the one technician. You have to have a backup system in place. So create redundancies in the system. Joint Commission comes in, CMS, one old school way of thinking. Let's call the educator. Let's call the manager who can answer all the questions. No, create redundancy. Every member of the team should be able should know their business, should be able to articulate operations, patient safety measurement cores, etc. So create redundancies in the system. That's a safe haven. It's very rare that your car has one airbag. Right?
Yeah. Yep. Amen.
Yeah. Give me just a second. I'm going to go ahead and introduce the individuals who we have here with us today. I was thinking, though, with the create, one of the places that I had the honor of going to, definitely we'll say no names here, but they had one guy. They had one guy, and he was the guy. So if he was out from Thursday until the next Monday or the next Tuesday, stuff just waited. They literally brought scopes over in pillowcases, and they would just sit there. And as well as I know, 4 days. Listen, you have a bio something's on there. It's been sitting that long. That's a long time. That's film, different things. But they had the one guy, and they didn't, what you say, create redundancy or cross train. Like I said, the language again gets there. But you want to be able to do that. But first, right now, I just want to take a moment. I want to say thanks to Danny Vasquez. You guys have seen Danny here. He's one of our repeat panelists. He is an emergency consultant. He hails out of the New York area. Definitely a subject matter expert as it relates to sterile processing, sterilization, different matters like that. LaWayne Perkins. He is the president of CS Assist, the #1 online resource for all things CS. So if you're needing help with the policies and procedures, and you need some help, you need some formats, some type of documentation, even just templates that'll help you, definitely CS Assist can help you with that. And Sharon Van Wickland here, PhD, Dr. Sharon, how are you? Yay, Dr. Sharon. You know what, side note, we're just gonna have a show where it's all Sharons. I'm gonna see if I can get Sharon Green. And it's gonna be you. We're gonna find us some other Sharons, and we're just gonna set it down. We're gonna represent for all Sharons.
I am completely in support of that. That'd be so funny.
Yeah, it's possible. All things are possible. And I just want to thank you, Sharon, for coming on and sharing your expertise. I know that you are right. I saw you writing on the tools of the trade within the Process magazine. You were talking about probes, high-level disinfecting, and just, I thank you. I thank you for just coming and sharing your expertise and your knowledge today. So again, we have subject matter experts here. If you have some questions, ask questions. We have about 6 to 8 more minutes. I see some things in the private chat, and I see some really good. Listen, I see Sharon. Sharon, you heard me. We're all going to be on here. I'm talking to the other Sharon now.
Sharon and Sharon. Here's one. Saturdays with Sharon.
Yes. You know what? Also, for those of you who are on right now, who are on the panel, if you would just put in the private chat, definitely I can let people know how they can get in contact with you if that's something you're interested in them doing, and I'll put it over there. Nowadays, they want the frontline technician to answer the questions, not the manager or the team leader.
Oh, yeah. They'll take tasks for the technician.
I think people just want answers. Okay, and this is what I love about this show. Remember earlier I said we don't have to agree on all things. We want to agree on universal precautions, remembering the drills, things that have to do with patient safety. But I think people want to answer. They just want a solid answer. If it's from the technician, that's fine. The tech may be the person they see first, but I think people just want an answer. I know working with executives and people who have authority, they're always looking for people who can solve problems. They just want an answer that's credible and that lines up, that doesn't endanger people or processes.
Oh, no, I think what Ms. Green Golden is talking about is when one of the agencies come through for inspection. Now they start questioning the technicians. Yeah. They don't want to go to the manager because the manager knows what's supposed to be happening, but we want to know if it's been communicated properly to the technicians. Then
yes,
hey, I've seen that. We Joint Commissioner DMV walks in with the charge nurse from upstairs, normally, you know, the ORs upstairs, and infection control and quality management, and this whole garage comes in, and you got your act together, right? You know exactly who you want to lead them. You want to take them to the education corner, the show them the beautiful banners, all of the awesome, colorful graphs. They bypass all that. They split the C's like the Red Sea, and they want to speak to the technician pressing the button on the sterilizer. You know, and, right? And for that technician, time stops. Right? Who else is in the room but the technician and his ginormous entourage? So I get it.
Oh my gosh. Let me help the technicians out there who, when you see everybody running around because Joint Commission's coming, or you entered into your window, and so everybody's at an elevated sense of urgency.
Oh, that's
I F you. I F you. Safe words.
That's right. That's right.
We had a technician at one of the facilities that we were helping, and Joint Commission came through, and they were like, "How much detergent do you put in there?" And they were like, "Well, I just squirt this much in," and that was their answer too. Like, "I just squirt this much," and it was different on different shifts, and so we're just like, "I F you, I F you."
I'm not gonna.
Okay, I get it now. Thanks, Danny. Thanks for making that plain for me.
Yeah, well, I'm not gonna name any facilities, but I know when they came through for inspection, they made sure I was in every room pressing that button. So I was just there, ready. I'm like, I don't want to answer these questions. They're like, no, go in front, go press the act like you're working, and just get ready. I'm like, okay.
Yeah, well, that's excellent. That's excellent. Hey, Sharon, is there anything you want to share with us about the probes? I mean, it's a very nice article. You talked about you talked about the teams working together. I know I just threw you on the spot right there, but
you know, I think that the thing that was so shocking for me was how dirty some of those probes were. And I mentioned earlier that when we were developing the AORN guideline for processing flexible endoscopes, we went through more than 1,300 studies. And some of the studies you would read, or the case reports you would read, it kind of make your stomach turn over, and you think, how could somebody do that? But you know, they do. And so I think it again just boils down to following those instructions, following those professional guidelines, and doing it every time. You know, just the old saying goes, if it was your mom on the table, or your dad on the table, or your husband or wife, brother, sister, if you do it that way all the time, as if that was the patient, then you're going to be delivering the best care that you possibly can. And I think that's kind of what it's all about with the scopes. It was shocking to me how dirty some of those ultrasound probes were.
Right. Something I realized, it only takes one corner to be cut for it to snowball into something bigger. Yeah. Because now you got accustomed to cutting that corner. So you're trying to see, like, all right, I'm supposed to check these hand pieces once a week. Let me just do it once a month. You know, it's now who's going to notice, until all of a sudden now you have a bunch of things failing on you, especially with surgical hand pieces, like the dental ones. You know, they should be cleaned after every use, thoroughly cleaned out. But then you have those once a week cleanings, or the once a month. And then when you inspect them, they have debris, they have blood all inside those crevices and inside the gear. So just don't cut corners, and create more. Just like you said, put your treat every patient as being treated like one of your own family members or loved ones. You know, you should process every tray in that manner. Like the person on the other end is going to be someone you know and care about, and you wouldn't want someone to cut a corner for you or your family member. So why cut a corner for someone else? You know.
Right. That's right.
I'm going to take a little break, show this commercial. Normally we have a hot seat question where hot seat, and I try to just make people seat warm, and they're like, oh, how do I answer? Today I like to do something a little different. Like I said, here I'm in Texas. Cases are volumes are up with the COVID, and I know we've been around COVID enough that it's not even just, it's still a buzzword for some, but it's been here long enough that the initial impact is there. My hot seat question today is not a question. It is me actually pulling on you all as subject matter experts. So as we're going over here to play this short commercial, I'm going to ask that you tap into your expertise and also tap into your heart, because people are working 12-hour days. People are working 16-hour days. People are working and grinding their fingers to the bone, and healthcare always gives 110%. You know, whether people were saying heroes or whatever, like there's something intrinsic or internal for you to remain in healthcare. You know, I say calling, but for you to remain in healthcare, it can't just be all about the money, or you would be bittered, frustrated, and afraid. And so I would like for us, instead of having a hot seat question, I would like for us to maybe encourage people who are out there working, whether that's in sterile processing, whether that is in facilities, you know, cleaning 3 times as hard, just the pressure of everything. Again, because people are working longer hours, people are still in healthcare, still getting sick by operating in healthcare, you're being exposed. And so you're getting sick, and everyone's not dying, but a lot of people are. And so that's the hot seat thing today. I'm going to ask that you share your heart. I'm going to ask that you share some of your expertise, and hopefully you'll have something to say. We just want to give people encouragement. There are days when I'm like, let's split this hair. Let's split this hair. Today, that's not the case. Today, people are working really hard, and they need a woosah, and they need some encouragement. And I'm going to pull on you all as subject matter experts to do it. And I will give you about 47 seconds to a minute to just don't be afraid to share your heart. There's no wrong answer for this. And if you don't have anything to say, don't try to push something. You know, you're free either way. I'm so grateful that you're here. So yeah, that is what we'll do. We'll be right back. All right, we are back. We are back. And so, who would like to go first?
Well, there's an amazing poem that her name is Kate Williams. She's a member of the Catholic Health Association. I'll share it on link, but it's so powerful. I just want to read some of it, if that's okay. The name of this is Bless All the Healthcare Workers. It says, Ms. Williams says, a blessing for healthcare workers in time of a pandemic. It says, blessed are the ones who cannot be isolated. Blessed are all the healthcare workers. Blessed are the hands that are raw from scrubbing and sanitizing, and the hands for healing, comforting, and supporting. Blessed are the shoulders that carry the weight of life and death. Blessed are the feet that are aching from standing at the bedside, running between rooms and answering phones. Blessed are the hearts that are frightened and breaking. Blessed are the mothers and fathers, grandmothers and granddaughters, sisters, brothers, partners, and friends who cannot go home. I'll post the rest of that poem. It's really powerful, and it totally resonates with all members of the healthcare team.
And yeah, I definitely want to share that, you know, I've been talking to a lot of my colleagues and peers, you know, a lot of nurses out there that have been in COVID units, and you know, it's very familiar and very common to come home and feel like, you know, you really can't share anything. Like you have no one that really understands or someone to talk to. You know, you don't want to really burden your family with what you saw, and you just feel like this almost like this isolated and a low feeling, and I just want to put it out there. I'm always here, just not only just to answer questions, but please message me, even if it's just a talk about your day. I always say, tell me your story. I've said that before in the show. I'm here to listen to your story. I won't say anything if you don't want me to, but I'm always here to listen. It's so important that we don't bottle anything, any of this struggle and this pain that we're going through. Like, we're all going through, like we said before, different stages of grieving, and it's just important for the nurses and all those healthcare workers on the front lines that they're trying to make patients healthy. We have to ensure that we stay healthy as well. So if anyone ever needs to talk, I'll put my LinkedIn information on the comments. Please shoot me a message. I'm here to listen. I'm here to talk. Whatever you need, I'm here for the community.
All right.
That's super eloquent. I don't think I really have much except to say thank you to everyone. And no matter you feel your job isn't that quote unquote important, it is. You're part of a great big team, and every member is important. And we're very thankful for the work that you do and the commitment that you have.
Right. And I'm right there with it. We're right at an hour. So I'm going to put the information in, Luane. I see that you've put something in the private chat. Oh, good. Everyone has put their information in there. So if it's okay with you, I'm going to put it into actually, I'm not going to put it in the chat. I'm going to create a banner and just set it across the banner. Or not. I may just put it in the chat for time's sake. I just want to say, for those out there working, you're working hard and we're appreciative. Again, sometimes the people who speak the first, speak the fastest or the loudest. Sometimes people can say really asinine things. And we just want you to know the majority of people are very grateful. We're humbled by the service that you give. Thank you. Please continue. We just send like kind thoughts and blessings your way. And we encourage you it's okay to take a break. Be free from false responsibility. You're given 150%. And because it's the nature of the call to want to do more. And like I said, if you're in healthcare, you're in healthcare. If it was easy, everyone would do it. But we're really grateful. And our hopes for you this week and every week, but specifically this week, is that there's some type of life-giving or refreshing, that there's something that you stumble across that's life-giving and refreshing and allows you to just have a woosah moment before you go back in for another 12, 16-hour day. Mm-hmm. And for those who are in the middle America, who are now experiencing some of the things that the hot spots were experiencing a couple of months ago, we want to encourage you to hold your form and let you know that we appreciate you as well. And humans are resilient. We can be arrogant, but we are resilient as well. And so just keep doing what you're doing. And we're very grateful and we're very thankful.
Thank you.
All right, thank you.
Okay, well, this is what I'll do. Thanks to SIPS Consults and CS Assist and Crunchy Rollers and other sponsors, and those of you who continue to support us. We've been doing this since had the idea in March. We've been doing it since April. We just want to bring information and help people be empowered to do what they're doing better. If there's someone you want to hear from, or there's a topic that needs addressed, please just send it to info@ucdileadership.com. And we'll bring it up. We'll talk about it. That's it. That's all I have to say. I'm going to put these things in the comments. Y'all have a nice night. And thanks again.
Have a great night. Thank you, everyone.
Thank you. Sarah, nice meeting you.
Nice meeting you too. Thank you. It was a pleasure.
Yeah, we're going to have a sharing day. We're going to have a sharing day. It's going to be good.
Yeah.
Yes, it's going to be bananas. That's excellent. I love it. Okay. All right, guys. Talk to you soon.
Today I want to talk to you about inheritance versus legacy. Inheritance versus legacy. Those are two separate things. Inheritance is what you leave behind. Legacy is who you leave behind. Inheritance is your life insurance policy. Inheritance is your house. Inheritance is your car. Inheritance is your money. When I die, my wife dies, my children, my grandchildren will have an inheritance. And I think that's a wonderful thing that every responsible person tries to leave an inheritance for their family. But that's different from leaving a legacy. A legacy is who you're going to leave behind. Who will say, he believed in me? Who will say, he gave me an opportunity? Who will say, when I was down, he picked me up? Who will say, he loaned me his credibility? Who will say, he invested in my life? Who will say that I'm here because of him? As good as inheritance is, it'll go away. The house will break down. The car will break down. Something will burn up. This will go away. This will live on. This is your legacy. The question is not, which one should I do? The question is, I know you're working on your inheritance, but I also want you to work on your legacy so you can leave an inheritance as well as a legacy.